Hi, this is Dr. Makela. Welcome to our Q&A. I put comments as you're here. It's a pleasure to see everyone again. Today we're going to be talking a little bit more about palliative care and hospice and geriatric medicine. This is the other part of my life. I am an expert in cannabis medicine, but I am also board certified doctor in hospice, palliative care, and geriatric medicine. I've been practicing for over 20 years. I taught geriatric medicine over at University of Illinois, and I am a medical director at a small hospice in Chicago, Affinity Hospice. If um, if anyone's in Chicago and needs hospice, you can look me up. Um, so I thought I would just reach out to people and talk a little bit about this part. Obviously, those of you who might be here from the cannabis last week um, are free to, if you have questions about how cannabis works in palliative care and in hospice, go ahead. Let's talk. Um, the first thing I'm going to talk about though is um, is what is palliative care and hospice. I think a lot of people probably know what hospice is. It's a program for people who are near the end of life. Generally, we say less than 6 months. Um, this was started only in 1983 in America when it was approved by Medicare. Years before, nurse Dame Cicely Saunders, she was knighted, she was out of England, um, was came up with the idea. And then it came over to America, and it wasn't until 2008 that it actually became a medical specialty. Um, Another doctor by the name of Martha Twaddle, just outside of Chicago, actually, really pushed for it to become a specialty with the American Academy of Hospice and Palliative Care and the hospice she worked at, training young doctors to become specialists. Before then, doctors who did hospice were just either geriatric doctors or ICU doctors or doctors who, you know, emergency room doctors, doctors who saw people often at the end of life, oncologists, of course. And so hospice and palliative care was kind of came out of that. Those were the doctors who ended up doing it. In 2008, they actually started having a specialty fellowship, a training program for doctors for hospice. Um, I actually sat for the first boards in 2008 because I'd already been doing hospice for 2 years by the time it became a specialty. So, hospice started. And then people started saying, well, that's great, but my patient doesn't want hospice. They are not very, comfortable at the end of life, or they have more than 6 months, or they might even be cured from this cancer. But you do great things. You get people out of pain, you get them comfortable, you help their nausea, you approach their symptoms, you make them feel better. Can you do that before they go into hospice? And thus palliative care was born. You know, and the other thing that in palliative care we do is we talk a lot about what people are. We talk a lot about what people want and what they don't want. Um, Talk a lot about goals of care. We say, hey, given your disease, given your age, given your values, what's important to you, what you want to do, what shall we do at this point? You know, do we talk about aggressive care and doing CPR, or do we not? And so palliative care is a lot of that sort of discussion. It's also a lot of symptom control, oh, you're sick, or oh, you're in pain, or you're uncomfortable. And we address that. So those are the two kind of arms of palliative care. And you can be in palliative care without being in hospice. In fact, that's why palliative care exists. Now, the other thing I do is I'm a geriatrician, and I think most people know that term. It's kind of like the opposite of a pediatrician, right? I work with people over 65. When you have people who are over 65, they're a little bit more prone to different things like medication side effects, for example, or they might be more likely to get dementia, or they might have a lot of chronic illnesses that all sort of pile together. So, if you have questions, things you want to talk about on this topic, we can talk about dementia. If you have a loved one with it and just want to learn more about what it is. We can talk about hospice and what it is. We can talk a little bit about palliative care. Um, we can talk about cannabis and how all that works together too. So there's some things we can talk about. Um, if you're here, feel free to just say hi. Hi, everyone who's here. Um, welcome. The so let's talk a little bit about dementia. Now, dementia is actually the main term. Everyone, you'll hear them say, "Oh, Alzheimer's." Oh, my grandma, she has Alzheimer's, or such and such has Alzheimer's, or Alzheimer's is this. They'll talk about that. Alzheimer's is only one type of dementia. There's actually several types of dementia out there, and I think it's important to know because as we talk about, oh my gosh, dementia's on the rise and Alzheimer's is on the rise, a lot of times it's not actually Alzheimer's. It's some of these other ones. And probably one of the biggest ones is cerebrovascular dementia or vascular dementia. Hey, Teresa. Nice to see you. So, we can talk about vascular dementia. And now, vascular dementia is very different than Alzheimer's. Alzheimer's is sort of an accumulation disease, it happens as you get older. There's a lot of theories that are competing right now, exactly what causes it, the amyloid versus the tau theory, and I'm not going to get into that today. But generally, as people get older, you start accumulating things in your brain, and these plaques start to develop, and they start causing damage, and that's Alzheimer's. Is these plaques building up? Now, it conversely, vascular dementia is very different. You're going to see vascular dementia is in people who have cardiovascular risk factors. They've had things like a heart attack before, or their kidneys are so so. They have high cholesterol and diabetes and high blood pressure, something like that. Things that are going to make you prone to heart disease or kidney failure or decreased blood flow to your feet, right? Decrease or strokes, right? And so what happens is in your brain, if you have the big arteries going to your brain that get clogged with cholesterol, a little heart attack with the brain, a stroke, right? That clogs off, that's a stroke. You wake up, half your body can't move, you have a stroke. Now, if it happens to a tiny, tiny little blood vessel, a capillary, you're not going to notice. You're going to wake up next day, live your life. It happens again and again and again and again, months and years over. You get these tiny little small strokes in small vessels in your brain. It starts to accumulate. You can even see it on a CT scan, these little speckled pattern. That is called vascular dementia because as that happens over time, you start getting real brain damage. Now, the problem with that, of course, is that's no good. That leads to dementia, because you start getting little spots in the brain that's not working right. That's dementia. Um, so that's vascular dementia. And what's important about it is it has a different look than Alzheimer's. Alzheimer's is going to be someone who lives to 85, 90. There is early onset Alzheimer's. It's a little different. but they're not going to generally have a lot of other risk factors. Yes, Alzheimer's can have some risk factors with people who are diabetic and stuff, but Alzheimer's generally is going to be someone who's fairly healthy who's starting to lose their memory as they get older, and it's a slow, steady decline. Vascular dementia is going to be someone who already has some diabetes or high blood pressure, or has had a heart attack, or has had to have their legs revascularized because they don't have blood flow to the legs, or has kidney problems. They have vascular disease. The blood vessels are coated with cholesterol, and it's the same is true with the brain. And the tiny blood vessels to the brain get affected and cause dementia. And so one of the other things is, unlike Alzheimer's, that's a kind of a steady decline. This is a little bit more of a drop and a plateau, a drop and a plateau. So you're going to see someone that'll be like, yeah, they've been fine. Then they went to the hospital, or then they got a urine infection, then something happened, and now they're so much worse than they were, and they never really got better from that. And then, 6 months ago, same thing happened. That's vascular dementia. And so when we talk about that, those are the two different things. And what's important to know is that vascular dementia is technically preventable. Um, Vascular dementia is part of this whole sort of chronic, disease thing of diabetes, high blood pressure, all that. You control those risk factors. You control your risk factors for vascular dementia. In fact, I've had people who I've put on medicines to control their blood pressure, control their cholesterol, and they stabilize. They don't have that continuous decline. Now, eventually they might, and it might still go down. You can't necessarily stop it all, but it does go down. Now, um, so then there's another one. There's Lewy body dementia, and that's kind of interesting because it's sort of, for lack of a better understanding, a hybrid between Parkinson's and Alzheimer's. You actually have memory loss, dementia, but you also have kind of the motor problems. Oddly enough, not so much the tremor, but the stiffness of Parkinson's, and you have hallucinations. People with Alzheimer's don't get hallucinations. So if someone's having hallucinations, Lewy body dementia is often to blame. um, Especially if you start seeing stuff that looks kind of Parkinson's on top of it. Now, people with very late Parkinson's, who've had Parkinson's for 10 years or so, can get hallucinations and memory loss as part of end stage Parkinson's. But what separates that two is that Lewy body dementia, those three things all start happening within a year of each other. That is Lewy body. Now, so one, two, three, those things. Now, the important thing about Lewy body is, again, it has actually a little bit of a faster course than Alzheimer's. It's a little bit rougher on the body. The other thing is the antipsychotic medicines that sometimes they might give someone if they're really acting out with dementia. When you give them um, that in Lewy body, you actually make them worse. Um, so That's why it's important, because you got to know what these different types of dementia are, because they have different treatments and they have different things that can affect them. Another type of dementia is frontal temporal. Everyone's, we've probably heard about that a little bit. There's had some movie stars who have gotten it recently, right? And that actually has a couple different variations. One of the things is that one actually does happen quite early in the 60s, usually, um, when people get it. And the other thing is there's two variations. Bruce Willis has the aphasic one, where he's losing the ability to talk. And interestingly enough, frontal temporal, your memory may be intact, but your logical reasoning isn't. So your ability to kind of figure things out is lost, but you can tell me what happened yesterday. And that throws a lot of people, because everyone assumes dementia means you can't remember anything. But frontal temporal, you can remember stuff, but your ability to reason things out eh, doesn't work as well. The other thing with that is you can have these two variations. One of them is an aphasic, where you a as in not phasic speaking. So where you start losing your vocabulary and your words become less and less and less. Bruce Willis has that. The other type is a type where instead of not speaking, you have a behavioral change where you, because the frontal lobe is kind of the thing that inhibits all your urges and stuff, you start having, you might start swearing a lot more. Your speech might be inappropriate, sexually speaking, stuff like that, right? Your behaviors might be inappropriate. And so that is the frontal temporal. And so those are some of the dementias. Hi, welcome. So those are some of the dementias, and that's why in the Jerry world, we just don't say Alzheimer's, we say dementia, because those are, different dementias are important to know. Now, as I've mentioned before, this is a Q and A. So if people have questions, feel free to throw them in the chat. I am here to answer them. Otherwise, I'll just keep talking about different topics. Um, One thing is we are live streaming on LinkedIn, YouTube, and Twitch. Twitch actually has a very liberal view about cannabis on like Facebook, so we're on there. Um, and I've been telling everyone, the kids were half teasing me. There is a video game called Schedule One, and they are telling me that I need to play it. I said if I get 10 Twitch subscribers, I will pick some Thursday night and play Schedule One while talking about the importance of needing to reschedule cannabis from Schedule One to something a little bit more sensible. Uh, and of course, you can guess what Schedule One, the video game, is about. Anyway, uh, just a little funny thing there. So, those are some of the things in geriatrics. Now, speaking of cannabis, one of the similarities I find as a palliative doctor, I mentioned early on that in 2008, palliative was actually recognized as a medical specialty. It wasn't even a medical specialty until then. Um, and hospice only came in 1983. So it has over the last many years evolved and is now every program in the country has a palliative care fellowship training program. I personally think that palliative care can pave the way for for cannabinoid medicine to be a specialty. For an endocannabinist, I guess is what you would call it. Because it's not just the endo, it's not just using cannabis. There's a whole, as I mentioned in my lecture last week, there's a whole other aspect of what the endocannabinoid system does in our body, and including like how the omega 3s and the omega 6s work to help prevent heart disease and diabetes and stuff like that. This whole thing, neuroprotection, all the stuff I've just been talking about, Alzheimer's and diabetes and stuff like that, is actually tied to the endocannabinoid system. So I personally think that that needs to be a medical specialty in of itself, and it's barely taught in medical schools. But palliative way can palliative care can kind of pave the way for that. So what I mean by that is, you know, 30 years ago, um, well, let's see, am I dating myself too much? I started in like 2008 when I took the palliative boards, right? So, 20 years ago, um, when I was first being a doctor, there was a lot of people who would look at hospice and think I was killing grandma. Um, it was a real story. Um, and I they would think I was killing grandma, right, as a hospice doctor. And, you know, it was the reality of it. There was kind of this sort of split thing. These days, most times when I say someone was in hospice, "Hey, Eric," um, when I tell people that I would do hospice, most people go, "Oh, that's so nice. That's so great." And then they tell me about someone they loved who went through hospice. Um, 20, 30 years ago, it wasn't necessarily like that. I actually had a doctor once tell me, they said, "Oh, I couldn't do what you do." And I'm like, "Oh, yeah." And then they finished their sentence and said, "Because my religion doesn't let me kill people." Huh? So hospice had this very negative connotation, for a long time. Um, there's still people who kind of are like, "Oh no." Um, and I think cannabis sort of has that same problem now. There's a lot of people who think it's just a bunch of drug addicts. And even the endocannabinoid system, which has nothing to do with cannabis except for the fact that cannabis works on it. But if we never took cannabis, the endocannabinoid system would still be in our body. Um, that cannabis is not cannabis, the endocannabinoid system. People hear that and they hear the cannabis and they think, "Oh, that's for druggies." You know, and I'm like, "No, no, it's not." So I think there's something to be said about that. Sorry, the dog decided to come downstairs. It'll be okay. Anyway, so people say, you know, and so there's first that negative stigma that they both share when they first started out. The second is the fact that it didn't start as an organ. You know, there's no palliative care organ, unlike cardiology or lung doctors or liver doctors. Palliative care started as a purpose. It was to help people at the end of the life or people who had a lot of symptoms that we could keep comfortable at their life. So that's palliative care. Now, the I'll get to that. It's a good question, Eric. The So I personally think that the pathway that palliative care took is a pathway that the study of the endocannabinoid system can take. You actually create a specialist. You say, yes, just like hospice was to serve a need of a program, of a business, a program, to have just like hospice was a program that doctors from other specialties, people who dealt with the end of life, would step in and say, "Oh, I'm going to work this. This will be my side job, or maybe even my full time job." But a lot of times it was just a side job. Um, that doctors would step in, eventually evolved to being a program that was recognized as its own specialty. But it took between 1983 and 2008 for that to happen. Just like now we have doctors who prescribe cannabis medicine from all over different fields in the medicine. Anyone who's kind of seen how this can help people, there are doctors who do that. I think it makes sense that there are doctors that eventually we're going to see that first, it's not just cannabis. It's really about balancing your ECS and about knowing how that works, right? And so those things kind of go back and forth. And that once we understand that we can actually make that into its own medical specialty. And that's what I hope to see someday. And I hope as a palliative doctor, I can kind of help lead that path. Now, a few questions that people popped in here with what made me choose working with geriatric patient populations? Honestly, I had a really great professor. Dr. Stott, God bless him. I have, I, he was an elderly gentleman when I first met him. I'm not sure. I know he retired, and that's the last I had seen of him years ago. But he was such an inspiration. He talked so much about the benefits of geriatrics, about how helping people at their older age was such a good thing. And he made it sound really nice. And you know what? I don't regret that. he wasn't wrong. There's something about that population that is very unique and different than other populations. As I mentioned, they use your body metabolizes medications different when you're older. You're a little bit more prone to side effects. It's definitely you get a lot more chronic diseases, a lot more complex cases, dementia. Uh, and then the other thing is that I find very interesting about geriatrics is it's a focus on a big picture. A lot of times in medicine, we look at the I'm going to look at the heart. I'm going to look at the liver. Okay, the heart's okay because we did this to it. The kidney's okay because we did this to it. And you kind of look at everything by pictures, right? Or little sections in bits. Here's my bit. Here's my bit. Geriatrics is extremely big picture. You're like, okay, good. But you have this and you have this and you this, and when big picture, you can kind of see it. And I think also that transitions a lot to the palliative and hospice world, where again, you're required to look at the whole person. In fact, both geriatrics and hospice, not only do you look at the whole person, you look at the whole structure of the person plus the family. You know, if the caregiver for your patient with dementia is not doing their job well because they're overstressed, maybe they're a 90-year-old spouse, right? That's going to affect the healthcare of your patient. Those things go hand in hand. That's why often in geriatrics and in hospice, you're going to have social workers and other people to help with those factors because it's a whole picture. That's what I loved about it. Now, I had another question. It's crucial for medical professionals to understand the ECS. There are those of us out here that are not doctors, but educators can help with the understanding. Regardless of cannabis itself, folks get lost. Exactly, right? There are so many people out there who just don't understand and we don't teach it in med school, and every time I say it, a little part of my brain says, "God, that sounds like a conspiracy theory." Because how many times do you, like, see some ad late at night, right? And someone's like, "Ooh, modern medicine doesn't like what I'm gonna tell you because it's a secret, big pharma." This is actually a real thing. For some reason, we learn about all these other systems, but not the natural body's system that's called the endocannabinoid system that cannabis just happens to work on. So if you have an issue where your cannabis system is low, such as MS, where it's broken, then cannabis can help it. But there are other situations where it's actually too high. Maybe cannabis isn't the right thing, or a different cannabinoid. Yes. Now, witnessing sundowning while working with geriatric patients in a nursing home played a big role to study neuroscience. Right? Sundowning. Oh my God. I saw this in my father in law too. It's a real thing. It's, and it's odd because it's like, why is it always happening right at like sundown? Tends to happen sometime between like 4 and 7 p.m. I wouldn't even say 8, like a little bit late. I would say it's in the late, even though they call it sundowning, I would call it in the late afternoon, somewhere around 4 o'clock it starts. And people who were normally okay start getting a lot more agitated, a lot more concern. And it's probably a little bit of that, the melatonin, right, in the brain, the natural melatonin or something in the circadian cycle that gets thrown off in advanced dementia. It's a real thing, and people can be very happy in the morning. There have been times at nursing homes I'll call if I talk to the day shift. Oh, they are the sweetest people. I talk to the night to afternoon shift. They're like, "Oh my God, she is screaming and yelling. I need something, doctor." And then the morning shift kind of gives me the side eye. Why are you giving her so many pills? And so that's a real thing. Sundowning with dementia, descheduling. Hey, Lashandra, nice to see you. So, deschedule, right? That's I don't know how many people heard, but I'm serious. If I get 10 Twitch subscribers, I'm going to pick a Thursday night and I will play the video game um I will play the video game Schedule 1, where apparently you start off of course, it's the gateway drug, right? I mean, I say that with tongue in cheek because those of us, who know about the cannabis really hate that whole gateway drug, argument. But level 1 is you start off growing cannabis and selling it on the Schedule 1 on the video game, and then you work your way up through different drugs. But I will play that while talking about descheduling if I get 10 Twitch subscribers. Uh, anyway, that was just funny. But yeah, right. Now, there are some people trying to really move to deschedule. There's a couple different things. Obviously, the whole reason I even jumped into this because I was scared for my DEA license. I'm a hospice doctor. I live and die by that. I can't do my job if I can't prescribe morphine for my patients. Cannabis is great, but when you have advanced cancer, that's in various morphine is needed at times. And so I was kind of playing in my head for years about doing something in the cannabis. You know, and I said, what do I say? I was like, well, I'd like to do it. But when they announced that they were going to consider changing it to Schedule 3, that's when I kind of made the jump. I was like, hmm, hmm, the Schedule 3, well, that means the FDA is not going to be coming for my license. And so that was great. Of course, they didn't actually do that. And now it's kind of back and forth. I do know there's a group called Americans for Safe Access. Now, they're only about the medical end of it. So if you're more into the recreational, they may not be the group you're looking for. Maybe normal or something might be more for that. But the Americans for Safe Access has been trying to actually say instead of Schedule 3, because Schedule 3 really doesn't change much. Schedule 3 means pharma can come in. That's what Schedule 3 means. It also changes the taxes. It also changes some of the banking regulations, maybe. But really, if you're doing things like we are doing it, we're still not doing it according to what a Schedule 3 would be. So it's not going to change things that much. Um, they were actually saying create a new schedule. I want to say the Schedule 5, schedule something, no, it doesn't it's not Schedule 5, but they were actually going to create a new designation just for cannabis and, specifically for medical cannabis to allow things going as they are. The And so yes, that is it needs to happen. And then descheduling would just mean we're just taking it off and it's just legal all across the board. Wouldn't be the worst thing in the world. I think I mean, we do that with alcohol and tobacco, you know. Why wouldn't we do that with cannabis? There are issues in the non-medical world. I do believe that there are some people who overuse to their own detriment, and that is an issue. I do think that DSM-5, when they called cannabis, um, when they changed it in DSM-5, so now that you have mild, oh, thank you, Schedule 6, they're calling it. Um, yeah, they're calling it schedules. They want to call it Schedule 6 with ASA. But agreed, that's how it should be. But descheduling would make it legal across the board. It might be easier, it might present some other problems. And like I said, there are issues. There are people who use it to the detriment of their own self. And, that's definitely where you would have issues with addiction. But just like we deal with that with alcohol and tobacco, why does it have to be a legal thing? I'm not a big fan of people being thrown in jail for this. Now, let's talk about it. I see a few questions have popped up, which is awesome. Okay. Sounds like the old card game called Grass from the 70s. I'm going to have to Google that one and read about that. I will tell you a funny story. I'm actually known among my friends as being the very straight laced one. I don't actually imbibe cannabis. and I don't do. And so when we play Cards Against Humanity, my friends now pull all of the cannabis cards for me, and they tease me about it. Now, the the DSM. Oh yeah, well that's what we're saying. The DSM-5 is terrible because they used to separate out dependence from addiction. So dependence would be stuff like physical dependence, like caffeine, right? If you don't have your caffeine, you get a bad headache. That is caffeine dependence. And what they've done is now they say if you have dependence and you have tolerance, so two things that can happen if because of a medical reason you have to take it every day, they now call that mild cannabis use disorder, and that's something I have a problem with too, right? That's just now in Illinois, cannabis is legal, but subsidized housing is federal and illegal. How can I create a case for this? You should like talk to the oh, yeah, there's a few people. I mean, maybe normal, the American for Safe Access, because really that's one of the biggest things is people can lose their housing if they're caught smoking cannabis in their housing. They can be evicted for this. That is terrible, you know, and it's legal, but because the housing is federal, we run into the same thing at the VA where you can't give it to veterans because it's federally. I can't give it in hospice because hospice is paid by Medicare. They have to get it from somewhere else, and I've never actually technically recommended it or signed it because I can't in my job. They have to give somewhere else, and I can tell them what and what not to ask for when they get to the dispensary. But I can't. Yeah, this it's crazy, Lashandra. And what you're talking about is one of the great injustices that the federal laws mean that federally subsidized housing, people can lose their homes over this. So, yes, I agree. Um, we covered this topic, and yes, excellent. I, why don't you put a link in the comments to your newsletter? I'm sure everyone would love to see it, Debbie. Go ahead if you have that. Um, we'll make sure that addiction, not likely dependence, maybe. Yes, that's what we're saying, the DSM-5. Oh, we are getting some things here. A physician is also caring for an elderly mother with dementia, a history of multiple myeloma in remission, and now diagnosed with myelodysplastic syndrome, trying to get as much info on hospice and other issues treatments. So, well, one thing you want to talk with, oh, it's continuing here. It just doesn't show up on there. As we start a new chapter of chemo. Where's the best source as a provider and a caretaker? Well, if she's still getting active chemo, one thing you would want to do is maybe talk to the oncologist. Is there a palliative doctor that they work with? A lot of oncologists will actually have palliative people in house um, that you can talk to. They might have a referral in their healthcare system. A lot of the big healthcare systems now have palliative doctors that work exclusively with them. Um, and so I would say your first best thing would be to ask the oncologist because ever since a study came out to show that palliative care actually extends people's lives, the, they have actually started using it more because that's good for their numbers. People, if you can tolerate the chemo, people live longer. And if you can tolerate the chemo with good palliative care. And then if you're talking hospice, especially when you're talking about myelodysplastic syndrome, where you're very prone to infections, you can have to get transfusions over and over. Hospice might be the right thing to talk to. So one way you can do it is ask to talk to a palliative doctor through your oncologist. The other thing would be to go to the oncologist and ask to speak to the social worker about hospice. A lot of times the social workers will have a list of hospices in your area, and sometimes they vet them. Sometimes, it's just someone they know. But generally speaking, your social worker is going to steer you towards a decent hospice to work with. That's what I would, those are the two places I would do. Yep. Let's see. Use disorder. Yeah, exactly. Type 2 use dis I think we've hit a nerve. I know I have. I oh, that drives me crazy, right? Didn't controlled substance start in the war? Yes. So, like, there's 2 things. There was I forget exactly when it was. It was like the 40s, 30s. Someone's gonna certainly correct me on that to tell me, when we actually started the Controlled Substance Act, but it was somewhere thereabouts, World War II, where we started saying it was illegal. Because it used to be just a patent medicine that people would, "Ooh, take cannabis for this." Guess what? A lot of the things that we actually thought it was good for now, like nausea, right? Um, but then the other thing that happened is in the 70s, you had Nixon come out and say, if we make cannabis fully illegal, and it was extremely racist. He was like, who votes Democrat? Well, black people and hippies, and they both like cannabis. It was kind of what he thought, right? And he figured if he made it illegal, then they were in jail and they couldn't vote for it. It was that was actually an admitted thing that his staffers years later said. Like, wow, just wow. And so that was the beginning of the war on drugs. And of course, then you go faster into the 80s and 90s with Nancy Reagan, Just Say No, and all that. So, where did what resources, treatments can I find in good old Texas where cannabis is illegal? Well, right now, that's tricky, especially as a doctor. You have to be careful because it's like we can't send them to stuff. I mean, technically, hemp is legal, because of the Farm Bill Act. Um, but I think Texas is trying to make that illegal too. I'm not sure where they were. Last I heard, it was still legal. Um, and that's actually been kind of the loophole in some of these states. The two places, yeah, that's been kind of the loophole in some of these places where it's been illegal. Um, is is actually the hemp options. But then it's hemp, you have to be careful because not everyone who makes it is doing it well quality, and there's not quite the checks. So they have to really try to find someone who makes it reliably well. And so that's the catch on that. Um, the hemp based THC isn't always produced stable. But let's go here. Um, oops, we got people asking questions. Excellent. Oh, hey, I'm just going to post this for a second. This is her website for the hospice, effectivenewsletter.com, and that's for her stuff about hospice and palliative. I told her to post that. Um, Seniors disabled, right? Disabled seniors being kicked out of their homes because they have to use cannabis for their. So, not only in Texas, but in any federal house. This is why we need it rescheduled. ICA Cares is interested in geriatric medicine and hospice care, especially as it relates to new communication medicine and dementia care. Ah, I don't know too much about that, Ethel, about ICA Cares, but thank you. Not sure why my name's not show. Oh, William Brown. Hey, William, nice to see you. Yeah, I don't know. We had that same problem last week. Drug restraints need, right? I know you've told me about BCP. I'm still reading up a little bit more about it, about whether it, um, how it can be used in place of it. That's definitely something to talk. People can talk with their doctors about to see if BCP is a better choice. Oh, I think we just had a, double click on that one. Fun fact: all during the late 19th, early century, cannabis was the most satisfactory medicine for migraines. Fabulous, and I'm not surprised. The that totally makes sense. Where we lost it. Oh, Dr. Philip Blair makes it really well if it's legal. Okay. That's where you can read more about BCP. I'm not as familiar with that one. Yeah. So that's a huge question, right? I mentioned about the hemp derived one, and that's the real challenge. You know, now I will take up one little issue here. Synthetic. Synthetic has been used and thrown around as a word like, oh, it's bad because it's synthetic. Okay, lots of things are synthetic. Synthetic just means it's chemically derived. So, dronabinol, which is the FDA approved cannabis THC, right, that we can get, is fully synthetic. It's made in a lab from start to finish because they couldn't use the cannabis because it was illegal when it first came out, completely illegal. And so dronabinol is fully synthetic, but it's FDA and approved to be safe, as safe as any other THC, right? And so synthetic doesn't make anything bad. What makes it bad is that if during the process of changing from hemp, because what you do is you take hemp and you take the CBD from the hemp, and then you do some little chemical manipulation. You add this, then add that. And by doing these chemical manipulations, you can create delta 8 or delta 9 THC. And delta 8 is chemically very similar to delta 9. It's just there's a double bond between the carbons. And in cannabis and in delta 9, it's at the ninth carbon. And in delta 8, it's at the eighth carbon. But that changes its binding, so it doesn't bind as effectively, which is why delta 8 is kind of considered a little bit lighter. Recently, some pharmacokinetic studies came out that I had just seen where they were saying that it's about half as strong. But when they do these changes, right, to make it, you're adding solvents, you're adding different chemicals, and first you got to make sure you clean them, that you got the solvents out. Then there are sometimes byproducts, delta 10, delta this, delta that, that can come out. And you got to be able to remove those byproducts. Now, if you do all that, then you actually have a decent product. Being synthetic itself isn't bad. The problem is that there's not a lot of stuff because there's not a lot of regulation. There's not a lot of regulation to say, hey, we need to make sure it's clean and what we're doing. Now, I know I went on here and people have been talking, and I wanted to really talk about Deb's point here. Texas has the Texas Cannabis Use Program. There are some cannabis specialists in Texas. So, back whoever asked about Texas, um, here, who was that? That was for Teresa Haskins. So, Deb, maybe you two want to reach out to each other, and I'll put her question up before here. So, Deb and Teresa, you guys might want to reach out together and talk to each other, and maybe she can help you get someone to help. Okay. Thanks, Thanks, Deb. Let me scroll back here. Okay. Yeah, BCP is all natural. Okay. Not nearly as effective as a safe plant. Right. Okay. Again, more about the BCP, pepper, cloves, etc., all natural without any side effects. Mm-hmm. Well, again, yeah, synthetics. Now, what you're talking about is maybe isolates, when you have something where you're just taking the THC and just taking, the CBD, and you're not getting all those terpenes and stuff. There is that whole idea of the entourage effect, which is cannabis as the plant itself in a natural extract of all of it, a full plant extract or a vaporized full plant, a dry vapor, not vaping, but where you actually take the plant and heat it up dry and then inhale without its burning. That is that can be there's a general theory that that is more useful and helpful, but we're still working, the entourage in this science, it still has to be proved. I myself am actually agree with you on that one. I personally would try to get full spectrum if you can. But there are sometimes situations where maybe you want a little bit more nuanced dose. Like maybe you want something very CBD heavy with just a little THC in it, or you want to change it. And that's where those concentrates can help. Yeah. Again, dronabinol. When I did geriatrics, we did this for dementia. This was approved for people who weren't eating very well. I was underwhelmed massively. It didn't seem to help the appetite. And in fact, you got people with um who got confused a lot about it. I would get, you have people with advanced dementia and you give them this big dose of dronabinol and maybe they're getting a little high and they don't know they're supposed to be getting high. And so it's not a good experience for them. So hang on a second. Okay. And that's a little bit about the health. There you go. Yes, the entourage effect. It's, as you were saying, I personally believe in it, even though there's not the data is still a little bit early. It makes sense to me that for years you'd be using the plant, and that's really what's helping people. Mhm. You know what? I will say that there's been some studies on Alzheimer's, and I would say that cannabis in the elderly, you want to actually have a little bit of a lower dose. You would do like 2.5, 1.25, but there were some studies that actually show that in elderly patients with advanced dementia, that it helped with sleep, it helped with behavior, it helped with agitation. And given the choices of drugs that we have for agitation, I still think it might be better for that. Now, I saw a longer question. I live in Canada. My family doctor is always on, and I need both cannabis. I have suffered from associated. You know, Here, let me just see. Oops. I'm just trying to read it all because it didn't fully fit onto there. I have suffered from bilateral trigeminal neuralgia associated with MS for over 40 years, diagnosed, and have had a hard time with PTS. Mm-hmm. My body's not cooperating. My pain is off. Wondering if you know how I could safely titrate my cannabis. You know what? I really can't be giving medical advice over the internet on this. There's a lot of cannabis specialists in Canada. You might want to just do some Google search to see if some of the cannabis specialists in Canada might be able to even do like a telehealth or something visit with you. Um, that's really all I can tell you. I can't really, without knowing all your medical stuff, tell you the best titration. And as far as psilocybin, I actually don't do much with psilocybin. I'm still learning about it myself only because there's a lot of it in the space right now of people talking about it. But it's not something I've had a lot of experience with, even though there is some increasing data that it can help with different things. You can FECO. You can formulate. Oh, is that like is FECO kind of like RSO but made with the different oils, right? I think that's what that I'm trying to remember the abbreviation there. I'm sorry that I kind of blanked out on that. But yes. Mhm. And yes, and I know you talk about and you say that the BCP also helps with sleep. Well, thank you for the information about that, Ethel. Appreciate that. Now let's see what else we got here. So the I'm going to write out a little bit more about the FECO to read about. D- no, no, full cannabis extract oil, right? Full extract cannabis oil. Sorry, typo. Okay. Oh, thank you. That's what. Appreciate it. Full cannabis, full extract cannabis oil. Yeah, the I myself am a fan of that actually, especially if you can get it in a tincture. The problem with RSO, I think, is that especially in my geriatric population, that little grain of rice is not that's a tiny little thing, you can do a tincture where you can a milliliter or two. But I mean, even in hospice, while I talk about how I would like to see a future where in hospice we work with people, at the end of life, and we give them a bottle of morphine, about yay big of what's called Roxanol, and it's 20 milligrams to 1 ml. So 20 milligrams. Just to put this in perspective, if you've not had morphine before, I would give you 5. In fact, five's a nice starting dose for anyone on hospice. I'm not going to kill anyone with that dose, not even an older person. No one. That's in fact the equivalent to one Norco. And yes, some people get really knocked out, so maybe a little less for some people, but it's equivalent to a Norco. That's why you start at 5. So 20 to 1 mil is a really concentrated dose, and it's designed for people at the end of life. So I can give a dose to it and put it in their cheek pouch and give less than a milligram and then rub it in. And at the end of life, when they can't swallow, it can still absorb sublingually. But the problem is that when you do that, well, there's no problem with it. That's actually how it works. But even that, RSO is still such a tiny amount compared to even that. But I would love to see a little concentrate of cannabis for people at the end of life that we could do the same thing for. There's an article to clear up the difference. Effective. Oh, hey, thank you. Good medicine starts with good. I'll have to click on it. I'll put this so everyone can see it. I'm assuming you mean like the difference between RSO. Oh, yes. Thanks, Deb. Here you go. Here, we'll do it again. So the difference between RSO and FECO. I really appreciate that. Thank you. Yeah, that is excellent. Thank you. And yeah, oh my gosh, time has flown. Can you believe it's already 3:58 already? We're winding up. So yeah, Deb, I have that for you. That looks like a great article to look at. Now, any other questions? The like I said, I actually came into this world via hospice, via geriatrics, because a lot of my patients benefited. Please sign up. Please sign up. Oh, welcome. Thank you. Please sign up, Doc. I'm sorry. It's still showing you as a user, so I'm not sure what you need signed up for here. But thank you. So I'm not sure which person posted that. So, oh yes, and thank you, Deb. Um, so like I said, I came in through via hospice, and I wanted to just kind of share a little bit some of these overlaps and a little bit about this. And what I'll be starting to do is like every other week. So next week it's going to be all cannabis again. Obviously, if you have a hospice question, not going to turn you down. But we're going to try to focus a little bit. And then the next week, um, we'll again be focusing for sort of the hospice and geriatrics and alternating. And and maybe every once in a while do something fun like play a video game while we talk about rescheduling or something like that. Anyway, folks, you have yourselves a great day. This was a wonderful conversation. Thank you for all of your information, all of your engagement. I will be talking to everyone next week, I hope. Um, in another week on the 28th and went next Wednesday. And you guys all have a great day. Take care. We will.